Bismillahirrahmanirrahim. My name is Dr. Sarhat, and I am Assistant Professor of Pulmonology at Gajuhan Medical College, Sawabi. Today, we will discuss respiratory failure, which is an important topic. Nowadays, you can see people wearing this mask, which is oxygen, simple face mask, or Venturi mask. Or some patients are using non-breathing mask, or some are on CPAP or BiPAP mask. So during this pandemic, the importance of respiratory failure are very much because of the lung involvement and COVID-19. So today we will discuss respiratory failure. Learning objectives of my presentations are: at the end of this presentation, students should be able to define respiratory failure, discuss types of respiratory failure, discuss clinical features and investigations of respiratory failure, discuss management of respiratory failure, and at the end, we will discuss the administration of oxygen to the patients. And the most important is the interpretation of arterial blood gases. Okay, now we will discuss the definition of respiratory failure. Most of the house officers coming to our ICU or pulmonology ward don't know what is respiratory failure. So you should know the definition of respiratory failure. Respiratory failure occurs when gas exchange is inadequate, resulting in hypoxemia and partial pressure of oxygen less than 8 kilopascal or 60 millimeter of mercury. So, for definition of respiratory failure, arterial blood gases is must. Without doing ABGs, one cannot say that this is respiratory failure. One can predict respiratory failure, but cannot say confidently that this is respiratory failure. So arterial blood gases is important, and you should know the interpretation of ABGs as well. We have two types of respiratory failure. One is type 1 respiratory failure and the other is type 2 respiratory failure. Mainly, lung has two functions. One is oxygenation and the other is ventilation. So if the problem is in oxygenation is inadequate. So this type of respiratory failure is called type 1 respiratory failure. And if the problem is in the washing out of carbon dioxide, so that is type 2 respiratory failure, that is ventilation problem. Type 1 respiratory failure, when partial pressure of oxygen is less than 60 millimeter of mercury with the lower limit normal or lower partial pressure of carbon dioxide, means that in type 1 respiratory failure, carbon dioxide level will be less than 35 millimeter of mercury, because patient will be tachypneic and they will wash carbon dioxide. If the respiratory failure is mild and patient is not so much tachypneic, so the CO2 level will be in lower limit normal. Causes of respiratory failure are pneumonia, pulmonary embolism, pulmonary edema, asthma, acute respiratory distress syndrome, and DPLD, diffuse parenchymal lung diseases or lung fibrosis. Now we will discuss type 2 respiratory failure. In type 2 respiratory failure, the partial pressure of oxygen will be less than 60 millimeter of mercury with a high purple with a high partial pressure of carbon dioxide, mean that in this type 2 respiratory failure, the PaO2 will be less than 60 and CO2 will be more than 45 millimeter of mercury. While in type 1, only PaCO2 will be low, PaO2 will be low, and PaCO2 will also be low. So the causes of type 2 respiratory failure are chronic obstructive pulmonary disease, late stage COPD, not early COPD, because in early COPD, patient can wash out CO2, and end stage of pneumonia, because if patient become tired and they cannot wash out oxygen, so they will accumulate CO2 in the blood and leads to type 2 respiratory failure. And also asthma exacerbation. When patient become chronic asthma that behaves like COPD, so they can retain CO2 during exacerbation. Or obstructive sleep apnea or obesity hypoventilation syndrome. And in kyphoscoliosis, when sedation are used, and CNS lesion, these are the causes of type 2 respiratory failure. Now we'll discuss the clinical features. First, we'll discuss the symptoms, which are dyspnea, headache, restlessness, agitation, drowsiness, coma, and confusion. These are the symptoms of respiratory failure. Discuss the signs of respiratory failure, which are tremors, cyanosis, tachypnea, polycythemia, or if respiratory failure is chronic, then there will be signs of pulmonary hypertension or cor pulmonale. How you will diagnose the respiratory failure? For that, some investigations are needed, which are baseline investigation like full blood count, urea creatinine, liver function test, and sugar, and you will do chest x-ray to look the involvement of lung and respiratory failure. Is it localized infection or generalized, or patient is suffering from ARDS? ECG is also required in respiratory failure to rule out cardiac causes and also to predict pulmonary embolism. And pulmonary embolism, there will be S1Q3T3 pattern in ECG, which is quite rare, but you will see sometime. And you will do echocardiography uh, because in acute mesopulmonary embolism, if patient presented with respiratory failure and shock, and there is mesopul P, then there will be pulmonary hypertension and acute right ventricular failure. So these are the signs of acute mesopulmonary embolism. Also, you will do ABGs, arterial blood gases, to confirm the diagnosis of respiratory failure. Here you will see the partial pressure of oxygen will be less than 60 millimeter of mercury. If oxygen is more than 60 millimeter of mercury, this is not respiratory failure. One is respiratory failure in the setting of general ward community. One is in the setting of intensive care unit. If PaO2 is less than 60 millimeter of mercury and without oxygen means on room air. So this is respiratory failure. This is the standard definition and classic definition of respiratory failure. But in the setting of intensive care unit, we say that if patient is on 10 liter of oxygen and his or her PaO2 is less than 60 mmHg, then this is respiratory failure. Sometimes specific tests are needed, like spirometry, nerve conduction studies, and CT scan brain to rule out space occupying lesion of the brain. Now we'll discuss the management of respiratory failure. First and important step is to treat the cause of respiratory failure. This is the most important step, treatment of the cause of respiratory failure. Another one is the supportive management, which is oxygen. In type 1 respiratory failure, high flow oxygen will be needed. The target saturation of oxygen will be more than 94, and sometime continuous positive airway pressure machine or required CPAP is required. But in type 2 respiratory failure, will give controlled oxygen, like in end stage COPD or obesity hypoventilation syndrome patient or kyphoscoliosis patient, will give controlled oxygen. The target saturation will be between 88 and 92% with oxygen. And here we will use BiPAP, bi-level positive airway pressure. So in type 2, we'll give CPAP, while in type 1, we will give CPAP, and in type 2 respiratory failure, BiPAP is recommended. So now we will discuss oxygen as a drug. Usually in ward, we see that we ask the ward boys or class 4 that kindly start oxygen to the patient. So this is not the good way. because oxygen is a drug and oxygen should be prescribed on the treatment chart. The amount of the dose of oxygen should be mentioned and the way that this oxygen should be administered to the patient. This is must, because if you give low oxygen, patient will not improve. There will be anaerobic respiration and patient will go into the lactic acidosis. And if you give more oxygen, especially to those patients which are on the verge of or risk of developing type 2 respiratory failure, then they can develop type 2 respiratory failure, because those patients respiratory efforts are due to dependent on the hypoxic drive. So when patient needs 1 to 5 liter of oxygen per minute, 1 to 5 liter per minute oxygen, then this should be given on the nasal cannula. And when the patient needs oxygen between 6 to 10 liter per minute, then oxygen face mask should be used. And when patient required more than 10 liter per minute oxygen, then non-rebreathing mask should be used. And when patient needs controlled oxygen, like in COPD, OHS, kyphoscoliosis, and those patient Venturi mask should be used. On left side, this is the image of nasal cannula. This is nasal cannula. On right side, this is oxygen face mask. स्टूडेंट्स जब हमारे पास आते हैं इवन डॉक्टर्स उस जॉब में, they don't know the names of these objects. So this is must, and you should know that when these items should be used. On left side, this is the image of non-rebreathing mask. When there is a balloon with the face mask and there is a valve with the face mask, this is the valve and this is the balloon and this is the tubing. So this is the non-rebreathing mask, and this NRM is used when the patient needs oxygen more than 10 liters per minute. On right side, this is the Venturi mask. Here you can see this is the face mask with the opening in the face mask. This is a long and large bore tubing with the different size cannula. The exact percentages of the oxygens are mentioned on these cannula, and these are used, which one is required to the patients. Okay, now we will discuss the arterial blood gas. Is the most important aspect of this presentation is ABG's interpretation. So everyone should know, because in exam you will get 1 or 2 questions from ABGs. So if you don't know, you will miss those 1 or 2 questions. And in ward or clinical setting, you will get ABGs on daily basis. So the normal values are pH is 7.35 to 7.45. The carbon dioxide partial pressure is between 35 to 45. You will remember this because in pH you can see 7.35 to 7.5 to 45, and also in CO2 is between 35. The last two values are uh, between the pH and CO2. These are the same. You can remember these values from here. The partial pressure of oxygen is between 80 to 100 mmHg. Bicarbonate is 22 to 28. Oxygen saturation more than 94% is normal. And the anion gap less than 12. These are the normal values. Now we will interpret the ABGs. So here are some steps which is you can interpret ABGs on the basis of these steps. Step one is to look at the pH. If the pH is less than 7.35, so the patient has acidosis. And if the patient is more than 7.45, so the pH is alkalosis. And if the pH is between 7.35 and 7.45, so this is normal pH. So this is step one, to look at the pH. Now moving towards the step two, which is look at the partial pressure of carbon dioxide. If carbon dioxide is less than 35, so this is alkalosis, because carbon dioxide is acidic gas. When the level of carbon dioxide decreases in the blood, so alkalosis, patient is moving towards the alkalosis. And if the level of carbon dioxide is increasing more than 45, so this is acidosis. So when you see partial pressure of carbon dioxide and pH, and both are going in same direction, then the problem is metabolic. If both are increasing or if both are decreasing, both are in same direction, this is metabolic problem. And if both these values are going in opposite direction, then the problem is respiratory. So यहाँ पर एक we will discuss an example. You can understand these two steps. Here, this is the example of a patient. His pH is 7.20. Partial pressure of carbon dioxide is 23. Partial pressure of oxygen is 54. Bicarbonate is 18. Here, step one, what was step one? Step one was to look at the pH. Here pH is 7.20. It means that pH is low. So the problem is acidosis. Main problem is acidosis. And step one. And what is step two? Step two was to look at the PCO2. Here PCO2 is also low. So pH is low, PCO2 is low. Both are going in same direction. Both are low. So the problem is metabolic problem. So what is the acid base disturbance? This is metabolic acidosis. We have discussed the two steps. Then example, we will discuss the another example of a patient which is pH is 7.20, PaCO2 is 73, partial pressure of oxygen 54, bicarb 34. Step 1, look at the pH, which is acidosis. Step 2 was look at the PCO2. So pH is low, PCO2 is 73, that is high. both are going in opposite direction. So the problem is respiratory problem. An example one problem was metabolic because both were going in same direction, while in this example these two values are going in different opposite direction. So the problem is respiratory. So step one, patient has acidosis and that is due to respiratory problem. So this is respiratory acidosis. Now we will discuss the step three. In step three, you will calculate the anion gap. We have anion in the blood and cation, and anion should be attached to cation in the blood, and these cannot flow in the blood freely. So these will attach to each other. And if there is some gap, deficiency or increase of some anion or cation, so there will be acid-base disturbance and the patient will be at risk of cardiac arrest. So what is the formula of anion gap? Anion gap is equal to sodium plus chloride plus bicarbonate. Sorry, this is not plus, this is minus. Sodium minus uh, chloride plus bicarb. This is anion gap. If anion gap is uh, more than 12, there will be anion gap metabolic acidosis. And when anion gap less than 12, so there will not be any anion gap. So this is non-anion gap metabolic acidosis. So we will discuss an example again. The example one to understand how to calculate anion gap. So in example one patient, uh, there were metabolic acidosis. The patient sodium was 143, chloride was uh, chloride was 95, bicarbonate was 18. Now calculate anion gap. So again, sorry, this is not plus, this is minus. This is minus. Okay. So 143 minus 95 plus 18, this is equal to 30. So the anion gap is more than 12. So this patient is also has anion gap. So he has anion gap metabolic acidosis. We have step 4, which is a bit difficult, and this will not be required in some cases. But if you know this step 4, it means that you know complete arterial blood gases. And step 4, you will apply Venter formula. We will discuss Venter formula just for metabolic problem. In metabolic acidosis, partial pressure of carbon dioxide drop by 1 with each 1 drop of bicarbonate. It means that when uh, one one bicarb drop, so there will be decrease of carbon dioxide by 1 for compensation of metabolic acidosis. And in metabolic alkalosis, there will be uh, two times increase in PaCO2 with one increase in bicarb. So this is Venter formula, and you will require this because to know whether this patient has uh, another metabolic or respiratory problem. Again, we will discuss the example. An example patient had bicarbonate drop 6 from 24. His bicarbonate was 18. Normal is between 22 to 28, but our normal in this case would be 24. So bicarb drop 6, and the partial pressure of carbon dioxide dropped 17 from 40. We will take 40 as a normal value. When we want to calculate the uh, decrease or increase from the bicarb and CO2. So respiratory alkalosis is also present in this patient. It means that patient has some compensation, but it is not fully compensated. When we will say that patient has fully compensated, when there is compensation and the patient pH is within the normal range, and the pH is not in the normal range, so and compensation is present, so that it will not be fully compensated. Okay, thank you. If you have any question, you can ask me.